Welcome to the Early Childhood Health Consultation January webinar. What we want you to know, quick tips every early childhood care provider should hear. I'm Erin Augustin, Outreach Specialist with Early Childhood Health Consultation. Our presenters today are our very own Early Childhood Health Consultation team, Dr. Depesh Navsaria, and nurse health consultants, Kristen Gabriel and Kelly O'Connor. ECHC is dedicated to supporting Wisconsin early education providers in promoting best health and safety practices. Our vision is a sustainable statewide model focused on the health and well-being of children across the state. Our partners are the Wisconsin Department of Children and Families and the University of Wisconsin-Madison School of Human Ecology. We're funded by the Preschool Development Grant and the Roots and Wings Foundation. Our mission is to support Wisconsin early childhood education providers in addressing health-related concerns and offering guidance on best health and safety practices. We acknowledge the American Indian tribal nations across Wisconsin and commit to offering tailored support to meet the needs of each tribal community. Our program provides general guidance on best practices for health and well-being in early childhood settings. For specific child-related questions, please consult the child's primary care medical home. Today's webinar will include introductions, central content, Q&A, and closing remarks. If you're interested in receiving credit with the Wisconsin Registry, stay tuned until the end of the webinar for a survey link. Registered participants will receive an email with links to the recording, slides, and resources. This recording will also be available on our YouTube channel. Please use the chat feature throughout the webinar to send messages to the hosts, panelists, or everyone. The Q&A feature is also available for your questions, which can be sent anonymously if you prefer by checking the box. If you joined the call via your cell phone, the chat and Q&A features are at the bottom of the panel. Now, I'd like to turn it over to Dr. Depesh Navsaria for today's featured presentation.
Erin, thank you so much. Really appreciate it. Happy New Year, everyone. Hope you're all doing well. I'm going to take just a moment here to get our slides up on the screen. And there we go. All right. So we're excited to spend some time today talking about some early childhood health and safety situations that often cause confusion and that may be the subject of myths. And I'm pleased to do that alongside our nurse consultants, Kelly O'Connor and Kristen Gabriel. Hello. We're going to also talk about some exclusion criteria, and we're going to identify, of course, how ECHC can help you with all of these things. I'll let them take it away.
Thank you, Dr. Navsaria. Hi, everyone. I'm Kristen. I am one of two nurse health consultants. Kelly and I are going to kind of be taking turns going through some different topics with you today. And just so everybody kind of knows what it'll be like, we're going to have a slide like this that says, hey, this is what we want you to know, which is the main point. And then we're going to talk a little bit more about kind of the background behind that. So to start off, what we want you to know is that the number on the thermometer tells you less than you might think. Next slide, please. All right, so for this one, we actually want to hear from you first before I kind of dive in. So if some of you don't mind sharing in the chat quickly, I want to know, how does your child care center define a fever? And what do you believe that the number on the thermometer tells you about a child? So for example, if you see a temperature of 100.6, what's different about that kiddo between that temperature and if their temperature was 102.6? I see above 100.5, 100.3, okay. Okay. So I'm seeing 100.3, 0.4, 0.5. Possible infection for the higher temperature, 100.7. 101 is when a child is sent home. Okay, they need emergency care. All right, well, I am seeing some similarities, but a lot of differences too. So I'm going to go ahead and jump into some information to tell you guys about fever and what it does actually tell us. Next slide, please. All right, so what is a fever? A fever is defined as that temperature of 100.4 or higher. I saw several of those. I saw several temperatures that were pretty similar being used. Something really important to know is that we do not add or subtract a degree based on the route. Therefore, whether we're taking the temperature by mouth, whether we're taking it by the armpit, which is also known as axillary, or any other way, the temperature is the number you see on the thermometer. Also know that fever is a symptom. It's not an illness itself. So a fever is like a cough or a runny nose. It just tells us part of what is the bigger picture. We need to kind of be looking at other things. And also fever alone is not harmful. So you might hear treat the child and not the number. That's because we want kiddos to be comfortable. We don't need to prevent them from having a fever. Next slide, please. So what does that number on the thermometer tell you? It's kind of helpful, but it really just tells us that the child's body is reacting to something. Now, that something can be one of many things. There could be a viral infection, like a common cold, upper respiratory infection. It could be a bacterial infection, like a urinary tract infection. It could be a reaction to a vaccine or a medication. You know, we're kind of coming off the several month period of everybody getting boosters of the COVID vaccine, the flu vaccine. So some of you might be thinking, oh yeah, I had a kiddo come in after their flu shot and they had a fever. Or intense exercise can cause an elevation of body temperature. And this is even more pronounced, you know, on those hot, humid summer days we have in Wisconsin, or even in the cold weather when those kids are a little too bundled up, that can elevate their temperature. But what the number on the thermometer does not tell you is how sick that child is. Everybody's bodies react differently, so we really just need to focus on the child and how they're acting and not the number on the thermometer. Next slide, please. All right, so when do we need to send a kiddo home who has a fever? Again, look at how they are acting, behavior change, other concerning symptoms. Now, the exception to that rule is a kiddo who's under 2 months old. They need immediate medical attention with or without any other symptoms if they have a fever. And that is because they haven't really built up immune systems yet, and there's a higher risk for meningitis, which can be really scary for those little babies. And then we have our key exclusion criteria for fever or really any other symptoms. Can the kid comfortably participate in activities? Can they follow your normal routine? Does the kid need more care than you can provide without compromising the health and safety of other children? You know, you're not going to be able to hold a miserable 2-year-old all day while caring for everybody else. And then the risk of spreading harmful disease, which when we talk about harmful disease, we're talking about, is it the measles or is it a cold? Next slide, please. And then I will turn it over to Kelly.
Thanks, Kristen. So our next topic that we want you to know about is pink eye. So most pink eye is less harmful than the common cold, is the theme of this topic. So let's start off with what is pink eye? What is actually causing the eye to appear pink? So there's a lot of teeny tiny little vessels all around our eyes. When there's an irritant in the eye, it can cause those little tiny teeny vessels to get a little bit bigger. That tiny increase of them looking bigger is what causes that kind of white part of our eyes to look a little pink. So that's what you're seeing when you're seeing a kid with pink eye. There's a lot of different things that can cause the eye to be irritated. One is viruses. Another is general irritants in the environment, like allergens, seasonal allergies or year-round allergies like dust. And bacteria is another thing. Another thing could be chemicals. Those are another thing we think of when we see an eye that's really pink. And the reality is, it's really, really hard to tell what is causing a kid to have pink eye just by looking at them. We kind of have to use the context clues around us to decipher what is causing this specific case of pink eye. So, for example, let's say this kid is healthy as a horse that day. It's a nice summer day. We're running around outside. They're rolling down a hill. And then they come back to you with like really pink eyes and they're rubbing them a lot. That kid might have gotten a little bit of an irritant, some grass or something in there that maybe they're a little bit allergic to. So we might consider, oh, this was probably an allergy in that case. There could be another kid in your class, maybe right now, because there's a lot of stuff going around that has a really runny nose, is sneezy, a coughy, and their eyes are really pink. That one we would probably think this is probably a viral pink eye. Other cases, you might see a ton of goop coming out of their eyes. Sometimes that is bacterial, but sometimes not. So those are kind of the things we're considering when we see a kiddo with pink eye. Now I kind of want to zone in on the ones that we typically worry about in an ECE environment. There's a lot of policies and stuff around contagiousness in pink eye. So the only forms of pink eye that are contagious are viral and bacterial. However, even though they are contagious, they are not harmful. They do not pose a risk to the child or other children around them. The only time we worry about pink eye is if their eyes also really, really hurt or their vision is infected. Those are both reasons I would want a kiddo to be seen. Other than that, like I said, it's really less harmful than a common cold. Um, so a lot of times we're seeing that kids are being prescribed or we want we're seeing that kids need to return to care with some sort of antibacterial eye drop if they're having pink eye. However, I just want everyone to know that antibacterial drops are not effective against viral pink eye and often are not recommended even with bacterial pink eye. And the reason for this is that kids recover on their own really quickly from pink eye typically. Again, I'll say if vision is affected or the eyes really hurt, that's a different story. But for most cases of pink eye, we don't see pain or vision change, and therefore it's okay to not treat with antibiotics. The reason for that, like I said, kids will fight it on their own really quickly and recover relatively quickly. And we don't ever want to overuse antibiotics because that can have negative effects on the body and our community. Another reason, like I was talking about, is if a chemical were to get in eyes. So let's say, you just like wiped it's a lot of germy season right now. You're wiping everything down with your cleaners and everything, and then a kid's playing with a toy, rubs their eye, and they get immediately red. That'd be a reason to wash out the eyes. We want to avoid having any chemicals in the eye, but that is another thing we see with pink eye. And now I think we can move on to the next topic.
Actually, I'm wondering, there's a few questions coming up in the chat, and
Oh,
just so we don't lose them, I wonder if we could briefly address them, if that's okay.
yeah, let's see. I might have lost them in the chat. Do you have them up in front of you, Depeche?
Yeah, so one is just simply a comment that somebody said that they had a young child that seized with a fever, quote unquote, at 99.9. Yeah, febrile seizures are scary but harmless. We've talked about that on some other webinars. And yes, they can happen at fairly low temperatures, and that can happen. However, treating fever does not necessarily prevent febrile seizures. There was another question about what do you suggest for early childhood providers is the best thermometer to use and what kind of technique?
So I would say stick to the more basic. Like the axillary is usually a good one for kiddos who can't keep their mouths closed. Axillary means in the armpit. The ear thermometers kind of have a record of not being quite so accurate. And, depending on how the kiddo's been laying, it could affect the temperature. The forehead ones, Dr. Nasaria, I'm not
Yeah.
quite sure about where those kind of stand.
If it's the forehead kind of digital ones, not the old school kind of LCD color changing strip ones, which are terrible, but they're actually reasonably accurate. They're more expensive, but it's also easy to use. So all of those are fine. I don't think one needs to really, I don't think the route is really a huge question there. There's a couple of questions about in a young child, how would you know if their vision is affected, especially since they're nonverbal, or if they're having eye pain or anything like that. I would actually refer you all to our we've had several webinars in which we've covered that and talked about vision changes, including kids who can't see well necessarily or have hearing problems. You would, it's what you'd expect. Are they squinting? Are they rubbing their eyes? Do they keep their eyes closed? Do they seem sensitive to light? All of those sorts of behavioral things that are in there. There's one more about took my child in for pink eye. Why did the doctor say they have to be out for 24 hours after drops? I don't have an answer to that. If that is not something that we would recommend at this point, it may be some old thinking that they're applying there. And then yeah, we will hold any remaining questions and move on to the next one, but we will try to get to them at the end.
All right, so the next topic, what we want you to know about RSV, which has been in the news and around a lot lately. Just because we didn't always test for it doesn't mean it wasn't common. Next slide, please. All right, so let's talk about the basics of RSV. RSV stands for respiratory syncytial virus. And I don't know about all of you guys, but that's a mouthful. I'm really glad we can call it RSV and everybody knows what we're talking about. RSV was actually first identified as a virus back in 1956, meaning it's been a known virus for almost 70 years. However, it's probably been around even longer than that before we figured out what it was. Just a little fun fact that I came across was that it originally was thought to be a chimpanzee virus, and it actually took a few years before they figured out it was a human virus. But so it's been around for a long time. However, testing hasn't increased until the recent decades. And as we know, if you're not testing, you don't know what people have. So a lot of reasons for it seeming like it's been so much more common is that we're actually testing for it more and we're getting those positive results and we're actually identifying that it's RSV versus the common cold, influenza, things like that. To kind of make a point about how common it really is, almost all children have been infected by RSV by the time they turn 2 years old. And that includes the majority of us as well. And for most people, RSV causes mild cold-like symptoms, which makes sense when we think about everybody's gotten RSV, but not everybody has spent time, hospitalized or in the emergency room really, really sick with this virus because it just seemed like a cold. I do want to acknowledge that, yes, there absolutely are more severe cases of RSV that require medical attention. Some of you might know that those more severe infections can lead to bronchiolitis or pneumonia. Those are both kind of lower respiratory infections. Bronchiolitis is where those smaller airways get swollen and it gets harder for the child to breathe. You might see some increased respiratory drive. And then pneumonia is an infection and there's some fluid in there and that requires treatment as well. Next slide, please. All right, so we're really concerned about those kiddos who are at higher risk of severe illness. And one of those groups are infants and young children. The younger means they're at higher risk. And on the next slide, we'll talk a little bit about how we can help protect those kiddos, which is something exciting that's kind of come in the last couple years. But then also infants who were born early or prematurely. Individuals with chronic lung disease, for example, asthma is one that most of you have probably heard of, or congenital heart defects. And anybody with a weakened immune system has a higher risk of getting really sick. Next slide, please. So how do you as providers help protect those high-risk kiddos that you're caring for? So the exciting thing that's come along in the last couple of years that I mentioned is that there's now a vaccine for pregnant women to help protect their newborn babies. It's given between 32 and 36 weeks of pregnancy and then protects that baby for 6 months after birth. Now, there's also an RSV antibody shot that can be given to babies and some young children. This is for babies younger than 8 months whose moms did not receive the vaccine. It's either given just before RSV season or within a week of birth if they are born kind of between October and March when we're already in the RSV season. So that's something great because those babies are the ones that can really get sick. But then also all the other kiddos you're caring for with special health care needs, their family should be discussing that particular child's risk factors with the child's primary care provider and kind of making a plan with them about what's the best plan for this child and how we can protect them. How can we keep them as healthy as possible? And that's just going to be an individual basis. And then, of course, as with all viruses, normal cleaning, sanitation is important, good hand hygiene, trying to teach those kiddos to cover their coughs and all that good stuff during this kind of winter and fall season that we're in. Next slide, please. All right, I'll turn it to Kelly.
Next topic we're going to talk about is diarrhea. So the drive home point here is that mushy stools are different than diarrhea. So there's this thing called the Bristol stool chart that we use in medicine. I don't have a picture of it here, but it's basically a spectrum of all the different types of poops kiddos and adults can have. It ranges from constipation, which is typically tiny, hard little rabbit turds, to diarrhea, which where we think of like really watery, liquid, frequent stools. So that's kind of the range of poop that we can have, with the middle being different levels of soft, mushy, or hard. I'm affectionately called the poop queen on our ECHC team. So I encourage any questions that you guys have, just drop them in the chat. So like I said, diarrhea is often the extreme end of the spectrum. So if a kid is having more mushy than normal stools, it doesn't necessarily mean it's diarrhea. There's a lot of other things that could be going on, that could be affecting their stools. That could be a change in diet, higher fiber diets, like they could be eating more fruit than normal. Any changes to our gut biome. Your gut biome is the typical like bacteria like good bacteria that lives in your gut that helps you digest. And everyone's is a little bit different. Medications they're on, sometimes if a kid is on an antibiotic, that can cause their stools to be a little bit runny because it's changing that gut biome that everybody has. Hydration is another one. We see a lot of kids who are dehydrated who have really, really hard stools. So if a kid becomes hydrated, sometimes their stools get a little bit mushier. So those are all things that we think of. As we all know, especially in this season right now, there's a lot of norovirus and other things going around. As a kid starts to become sick, there's kind of this like really gray area. You're like, ooh, their stool's different, but also they just, had a bunch of strawberries yesterday and a lot of changes in diet. I don't know if this is an illness or not. Don't panic, just start washing your hands. Washing our hands frequently, especially before we're eating, after we change a diaper, or after a kid who's, potty training uses the bathroom, whether it's pee or poop, really important to wash your hands with soap and water for 20 seconds. And that's a really effective way to decrease spread of illnesses that are spread in feces, stool, poop, whatever you want to call it. Another thing that I want to talk about, a situation that we see sometimes in really young kids, is if they have a lot of constipation, they have a lot of hard stool in there. Sometimes liquid stool will kind of leak around that pretty frequently. So if you see a kid that you're like, I don't know, they're having, like 10 little tiny liquid stools a day, is that diarrhea? It actually might be constipation. And stool is kind of making its way around those harder stools. So that's a scenario that we see sometimes. Another scenario we see with constipation while we're talking about it is if kids are potty trained and they're, wetting the bed all of a sudden, sometimes that means there's a lot of stool in there, kind of pressing on different parts of all the organs that are down there, and can make them incontinent or, wet themselves, even if they're potty trained. So that's another scenario that I like to think about sometimes. And let's see, there's a couple different medicines out there that adults, can take to slow down their stools. Um, I just want to do a PSA that a lot of times if a kid or an adult is really sick and they're having a lot of stools, that's the body's way of saying like, I got to get this out of me. Like, there's norovirus or if there's another illness causing it. In those scenarios, we want to be really careful about deciding to take medicine that slows down our stools because the body's trying to kind of get that out. So I would probably contact a healthcare provider before giving a kid any medicine to slow down their stools. And I think we can move on to the next topic now.
I think "Don't panic, wash your hands" would make a really great poster, Kelly. I like it.
Love the poop queen.
All right. If you don't mind, I saw a couple good questions in the chat about RSV, so I just wanted to jump back to those before I move on. So if there's a positive case of RSV in an infant room, do you recommend any exclusion of other children who appear sick? No, no matter what the virus is, the exclusion criteria remain the same. RSV, COVID, influenza, any sort of common cold. We're not going to increase our exclusion based on what we know might be circulating. That's a really great question, though. And then another RSV related question that I see: can an immune compromised older adult with RSV pass on to children? Yeah, it's just like any respiratory virus. Anybody who's infected with RSV can pass it to anybody else. Now, if that older adult is immune compromised, they actually might be a lot more sick than the child, depending on the child's age and immune system. But absolutely, it spreads the same way as any of those other respiratory viruses. Good question. Oh, go ahead.
There's a couple of questions about poop as well. Any suggestions for kids who don't poop all day and will hold it until they get home?
That's a great question. I would say as long as the kid is pooping regularly, that's okay. A lot of even adults kind of their bodies won't kick in into I gotta poop mode until they get home. Humans are kind of wired in that way. It's just kind of a funny thing about poop. So I would say that that's okay. You don't need to force them or give them medicine to try to poop while they're not at home. I see another one around teething. Teething is actually not associated with an increase or change in stools. That's something that we don't see.
And I know there's some other questions about teething. We're going to hold those for the end to take those on, but yes, agree with that. There's also a question about how do you feel about parents who frequently want to use stool softeners?
That's a great question. I think that as long as the kid isn't becoming dehydrated from using a lot of stool softeners, that's okay because constipation is a really common issue in early childhood. So I think that if they are using a lot of stool softeners, maybe a primary care doctor had recommended that to them. So I would say that that's okay if the parents are wanting to do that.
And I
Yeah,
can share from my own experience with a kiddo who had one of my own kids, really hard stool. Then we had to kind of use the stool softeners to get her to be okay with pooping again because it hurt. So sometimes the stool softeners can help with that as well.
that is actually one of the most common scenarios is that kids are constipated because they keep holding their stool because it hurts, and you can see how that becomes a cycle. So they may actually be doing that on the advice of healthcare, and they may be on stool softeners for months, and that is okay. If it's not being done under medical advice and a child is chronically constipated, that might be reasonable for them to actually seek some medical advice on at some point. There's a question about if stool is consistently coming out of a diaper. Is this a reason for exclusion? It's a sanitary issue in the classroom, and some children will have this happen for days after being ill, and it's hard to keep sending them home. And indeed, exclusion criteria do say that if it's I think it's more than two stools that cannot be contained. Thank you for confirming that I'm doing this from memory. That cannot be contained then within the diaper, then yes, that is a reason for exclusion for exactly those reasons. You can't have poop all over the classroom or anywhere else. That's not okay. Okay, we will move on. Again, if we're not getting to your questions, just because we're trying to hold it for when we have a little more time at the end. We want to make sure we get through all of our other topics as well, but we will get to them.
All right. So what we want you to know is that sending a sick child home may not protect your classroom as much as you might think. Next slide, please. So did you know that many illnesses are actually contagious before any symptoms develop? Meaning that kids are spreading germs, adults too, before we even know that they're sick. So a couple examples of this are influenza. The contagious period begins about a day before symptoms, and this is pretty in line, usually 24 to 48 hours for a lot of those respiratory viruses. And this one will get you scratching your head. Head lice can be present for up to 4 to 6 weeks before itching develops. So a kiddo could have nits, live lice for over a month before we have any idea that it's been spreading through the classroom for that long. And the longer side of that time frame, it's usually that first infestation. If a kid has lice a second time, sometimes the symptoms might start a bit sooner, but still it can be around for a long time before we have any idea what we're dealing with. Next slide, please. All right, and did you know that children can be infected with a viral illness and not show any symptoms? So this is different from, right, we just talked about them becoming contagious before they even started having symptoms, but sometimes a kiddo or an adult or anybody just doesn't have symptoms at all, but they're still spreading. And this term is known as asymptomatic. That might sound familiar from all the COVID verbiage that kind of came out a few years ago. We talked a lot about those asymptomatic spreaders. But again, even without symptoms, these kids are still spreading the virus, including throughout the classroom. And did you know that symptoms of the same illness can vary pretty greatly from child to child? So an example here, 2 children exposed to the same upper respiratory illness, same time, same manner. Maybe they've both been playing with the same kid for the same amount of time. But then one kid, sore throat, congestion, icky cough, fever, just low energy, right? I look at child A and I think, oh yeah, this kiddo probably needs to go home and rest at home. Probably a little too much for care today. But then child B with the same illness, maybe some mild congestion, a mild cough, normal energy, eating, sleeping, having fun, playing, they're probably going to get to stay at care. So we sent one sick kid home, but we have a different kid who's still contagious, but healthy enough to be at care. Next slide, please. So how much does sending a sick child home help to protect others? So again, by the time a child develops symptoms, it's likely that many other children in your care have already been exposed, meaning we're not really removing that illness. It's still going to remain in the classroom. By the time you're concerned about a symptomatic child spreading an illness to others, there's a good chance that multiple other children have the same illness already. So again, still contagious, still spreading it. So really kind of the main point here is that sending a sick child home from care might not prevent others from getting sick as much as you might think. And I'm sure a lot of you are really feeling this with these just kind of never-ending cycles of illnesses running through your classrooms. Next slide, please. So even though it's hard to remove illness and that can be really frustrating, just some really important points to know is that while frustrating, it is normal, it's common for young children to become infected with multiple viral illnesses each year. It can seem like a never-ending cycle, but it's a very normal part of childhood. Great news is that many illnesses result in only mild symptoms for children. So most kids aren't going to get ill enough to require going to the doctor, hospitalization, things like that we get really worried about. And many illnesses are also self-limiting, which means that they get better without treatment. So while you might have a kid who's just not themselves for a few days, they're most likely going to get better and be back up and running soon. Next slide, please. So again, you saw this little chart with the exclusion criteria earlier, but again, when should a sick child be sent home? We're talking again about how's that child acting? Can they participate? Can you care for them along with everybody else? Are we concerned that it's a harmful disease versus a more common virus? And then there's a couple links in there. We're not going to go into those now, but we're going to make sure those are along with the posting of the webinar. Some symptom-based exclusion criteria. Caring for our children has a really great inclusion and exclusion chart. It's evidence-based. And then we have our own ECHC health policy template wizard that helps you make easy health policies based on that evidence-based best practice criteria. So that link will take you to our page where you can learn more and create an account and make your own health policy if you'd like to. Next slide, please. All right, back to Kelly.
So next topic we want to cover is hand washing. So hand washing with soap and water is better than using hand sanitizer, always. So like I said, hand washing is always the preferred method if available, compared to using hand sanitizer. When done properly, it will decrease the spread of all types of illnesses, whereas hand sanitizer only decreases the spread of certain types of illnesses and certain scenarios. So the goal when we are washing our hands is not to kill the germs on our hands, it's to remove them completely from your hands. So that's why the 20 seconds with lots of friction covering all surfaces of your hands is really important, because we aren't killing the germs, we're removing them. This is also the reason why antibacterial soap is unnecessary, and really all it does is dry out your skin. Because like I said, the point isn't to be antibacterial, the point is to wash it away and wash it off. I will talk about hand sanitizer for a little bit. So hand sanitizer is typically alcohol-based. You need 60% alcohol in order to kill the germs that they're after. If your hands are visibly dirty, it's not appropriate to use hand sanitizer, because it doesn't have the ability to wash away those germs. Those will probably still be there after you use the hand sanitizer. Hand sanitizer is also not effective against certain germs that have this protective shell around them. Those are often viruses and bacteria that we find in poop and dirt. So some viruses and conditions that aren't appropriate to use hand sanitizer are common ones that are going around right now, like norovirus and hand, foot, mouth. Both of those, it is much better to wash your hands with soap and water to decrease the spread of those specific illnesses. So let's say you're changing a kid's diaper and you have gloves on. It's still best practice to wash your hands with soap and water, not hand sanitizer, after removing those gloves. Because we know that there's going to be poop germs on those gloves that can potentially transfer into your hands as you're removing those gloves. So that's just something, especially in this season where a lot of norovirus is going around right now. I just want to emphasize soap and water is best. I will give a shout out to hand sanitizer. It is nice that you don't need clean running water to use it, and it is effective against some illnesses like the common cold and RSV. So if you're seeing a lot of like coughy, sneezy stuff going around, it is okay to use hand sanitizer as long as you don't have like a pool of boogers in your hands. Let's see. But like I said, if there's a lot of pukey, poopy going around, wash your hands, even if you're wearing gloves. This is a poster that I really like. It talks about a strategy of timing for washing your hands, because in nursing, there's actually a study done that if a nurse was to wash their hands every time that like the hospital policy recommended, we would spend 12 hours a day washing our hands. So similar to early childhood, every time I'm telling you to wash your hands, you'd probably be washing your hands literally all day. So be really strategic and do your best about these times. So before you're eating, before a kid is eating, after you change a diaper, those are really critical times to wash your hands. if you touch something where like, ooh, like I know that thing was probably pretty germy, try really hard not to touch your face or another kid's face until you can get to a sink with soap and water. So I just want to say I really empathize with feeling like you need to wash your hands all day and do your best and be strategic about the timing.
There's a couple of questions that are related to what we just discussed that I thought we could briefly address. If you dilute soap, does it reduce the effectiveness? It shouldn't unless you're diluting it so much that there's barely any soap in there. But yeah, soap works pretty well. Is it effective to use both hand sanitizer and hand washing together? Not really. You're probably just drying out your skin more by doing both together. So there's no reason to use both. Um, and foam soap is still soap, so that's completely okay. I do see a comment about a licensor saying that you can't use hand sanitizer at all, regardless of situation. That would be something to take up with licensing. I'm not aware that there's a prohibition against that, but that is on the licensing side and all. There's also another question. Is there a rule in Wisconsin that um, I think they mean should have warm water in a toddler room? Apparently theirs is shut off, and with winter, I feel it doesn't kill the germs as much, and their hands get rough and sore with ice cold water. I would direct those licensing questions to licensing, but I gotta say, in the winter, only having cold water available, this doesn't sound very pleasant. Um, and you're less likely to wash your hands if you're like, ugh, my hands are going to be, frozen from doing this. So it seems like it's a wise thing to make sure that there is warm water. And I do see a comment from someone in licensing saying, yes, the rule does require warm running water. So if your warm water is shut off, that sounds like a potential violation. I will let you communicate with licensing about that if you need to. So uh, great. All right, and then I have the last two here. So one is on vaccines help in more ways than one. So I want to briefly remind people about how vaccines work. All of them are different in different ways, but they all do the same basic thing. They actually imitate an infection to teach the body how to defend itself. Okay, so what they're doing is looking like the infection just enough so that your immune system actually says, ah, I now know how to fight this thing and develop that immune memory, but it's been modified in a way that it won't actually cause the illness. Um, the two words that you might hear are antibodies and antigens. Antigens are stuff that causes immunity. Okay, that's the basic way I define it. And antibodies are what your body produces that would give you memory, give your body the memory to remember that item that is causing an issue and be able to defend itself. So the first time you get sick from something, if you've never seen it before, you don't have any antibodies. So, you know, you have another part of your immune system that will spend some time fighting it and developing that memory. The second time, or the third time, or the fourth time, if you have that immune memory, you're able to knock it out much sooner. In fact, you may not even feel sick at all because your immune system immediately recognizes it and takes care of it. So with vaccination, we're trying to jumpstart that process so that you never have to get the illness in the first place, or maybe a much milder version of the illness because nothing's perfect. This is a tweet that has gone around, has been shared quite a bit. This is a real tweet. I did find it a couple of years ago. This is from someone who's very well known for being against vaccines. And he literally said just this. This is the entire tweet. What if instead of a vaccine, we just were able to get exposed to a weak version of the virus that enabled us to build the antibodies we need to fight the real thing? Um, that is literally what a vaccine does. So, yes, I just saw that and just shook my head and said, that's actually what it is. So, the other thing to remember is that people are different. So, not everyone will get full immunity from one round of vaccination or even, whatever the recommended number of doses is. Some people will gain weaker immunity, And some people may not actually develop immunity. That's because, again, there's a limit to how many times we can tell people to receive immunizations and how much we can check to see what their response was and how long does it last. So what they do in the studies is say, how many doses do we need for most people to develop reasonable immunity? And this is a concept known as group immunity. You might have heard the term herd immunity, same thing. This is when enough people in a group are immunized and therefore have developed immunity against some particular disease. And this makes it much harder to spread. Let me give you extreme examples. If only 5% of people in a population have immunity and then the virus shows up, hey, guess what? 95%, it's going to spread real fast. However, what if it's the opposite? What if 95% of people are immunized and only 5% are not? Maybe they didn't develop good immunity. Maybe they are unable to be immunized in the rare cases, right, that exist that they can't, severe allergy to the vaccine components or something like that. Very small number of people, but they do exist. Well, if 95% are immunized, that virus shows up, it doesn't even have the opportunity to infect most people there. So it's less likely to get to those few people who actually don't have immunity. So we need to recognize that this makes a big difference. And particularly for babies, for young children, right? We can't immunize very young babies against some things. It makes a big difference. Um, to immunize the people around them. In fact, for example, there is a concept called cocooning, where we will actually ask both mothers, fathers, anyone else in the household, right? Are you immunized against whooping cough? And when was it last updated? Because for babies, whooping cough can be a big deal. So what we do is say, can we immunize everyone else in the household to reduce the risk that it would spread to that newborn baby when they're born? So this is just a graph that I pulled on measles, and it looks complicated, but let me take it apart for you. This is on the bottom is years, okay? The year 1930, so yikes, almost 100 years ago, to about 2000. And the vertical part is how many cases of measles were seen globally. And you can see the dashed line in the middle is when measles vaccine was introduced. And you can see as measles vaccine rolled out and we had more group immunity throughout big populations, look at what happened to the number of cases of measles. Absolutely plummeted big time. This is great. This is fantastic. So when people tell you things like, oh, well, they don't really work or things like that, yeah, they're not looking at the data or they're only showing you very select parts of the data where there's little blips and tweeps and whatever, right? No, vaccines work. They save lives. They make a big difference. Pertussis or whooping cough is actually a great example. And if any of you listen to our podcast from ECHC, Teachers, Toddlers, and Tissues, we just dropped an episode on this in the last week. There's a lot of whooping cough going around. In fact, I think Wisconsin may have the third highest rate of whooping cough in the country. Whooping cough is caused by a bacterium. It is something that is for older kids and adults. It's an annoyance. It's a cough that just is really annoying and goes on for weeks and will eventually go away, but it's not fun. It can be fatal for infants. And if you listen to that podcast episode, we actually managed to find audio of an infant with whooping cough, and you can hear them struggling to breathe. And babies die from whooping cough. So this is why it's a big deal that it's out there in the community, and it can cause all sorts of issues. Uh, why is whooping cough going up? There might be some small mutations in the bacteria that causes it. There might be some other issues. But honestly, some of it is also many people are not getting their pertussis immunizations on time. Partly it's left over from the pandemic, from interruptions in healthcare, et cetera. also people listening to folks who are against vaccines and all. I want to highlight just, I want to really underscore how serious this is because, again, this can cause big problems for infants. I have here a book. This is from the American Academy of Pediatrics. It's a book of their first 75 years, which was way back in 2005. So the book's a little older. But um, let me just tell you what the reality used to be like in for people in healthcare in the middle part of the 20th century. This is Dr. Annunziato. In 1946, I was a resident in Providence, Rhode Island. Pertussis patients were housed in a separate building containing 30 rooms, each with two bassinets. Many babies had serious complications ranging from hemorrhages of the brain to pneumonia that caused most of the deaths in these infants. Rarely we saw rectal prolapse, umbilical herniation, or toxic encephalitis. If the front lower incisor teeth, the bottom lower teeth in the front, had erupted, lacerations of the frenulum, that's that little tag of skin there between the lip and the gum, lacerations occurred and babies died. It was a horrendous disease that was called a 6-week disease. 2 weeks coming, 2 weeks staying, and 2 weeks going. To watch these infants whooping in spasms and screaming in between was frightening, frustrating, and unforgettable. We held our breath with them, waiting for the next inhalation. Pertussis vaccine reduced the incidence of pertussis dramatically, but there are still several thousand cases in the United States each year, usually occurring in babies who were not vaccinated either because of lack of access to medical care or because of parental fears about side effects. I don't ever want us to go back to that world. So just wanted to highlight that vaccines work, they save lives. Last thing before we go to questions is testing for illnesses is often not necessary or medically helpful. So often people come in and they're told, oh, I want to test for this disease, or I've been told that I need to get a test for this before my child can go back, or things like that. In healthcare, the single most important question we should always be asking around testing is, does the result of this test change what we do? Because otherwise, we may be spending a lot of money to say, everything I told you, doesn't matter what the test result is, do all those same things. That frequently happens. For example, RSV testing is one. They might have gotten an RSV test at the door of urgent care, and by the time I see them, I actually say if this kid is going home, they're fine, they don't need hospitalization. If it's RSV positive or if it's RSV negative, I'm going to give the exact same answer, and it's actually not going to change, as we pointed out earlier today, about the return to care. Okay, so I would recommend not setting up, talking to parents and giving them an expectation that testing will be done or won't be done. Now, sometimes it may change things. For example, if you do COVID or flu testing, even the home tests that you do, either you have it or you don't, right? You have COVID or you don't have COVID. You do have flu, you don't have flu. Strep is a little different. It's not as simple as doing a test. Some people are carriers but have no symptoms, and that happens to a lot of people. So we in healthcare need to actually talk through what the symptoms are and decide whether it's actually necessary to do those things. So please do not require or even suggest testing unless we're in an unusual situation where public health is saying, hey, we actually do recommend that there be testing in a particular situation. And that's pretty rare. So I want to make sure that we cover those. All right. Let's get to some of these questions here in the last few minutes. Again, you can do so in the Q&A or the chat as you have been doing all along. And let me try to address a few of the ones that we had here. Let me get to the one that many of you asked about, which is about teething. Teething does not cause fevers. We talked about how it doesn't cause diarrhea. It does not cause fevers. It probably does not even cause fussiness or pain or irritation. And this might be blowing your mind as I say this all. But the reality is that we have no scientific evidence that a tooth coming through an infant's gum actually causes any distress at all. We don't see it in older kids who are getting their adult teeth. We can push on the gum and it doesn't seem to cause issues. Babies will mouth things because that's how they explore the world, but it's not actually going to change. It doesn't say anything about their gums. In fact, if your gums hurt, why would you mouth things? The reality is, as we said, many young children get many viruses. That diarrhea, fevers, fussiness, etc., are probably from these innumerable common viruses that happen, and they likely have nothing to do with gums, with teeth coming through gums or teething or anything like that. This is why we don't recommend putting things on the gum, like, numbing agents or things like that. Sometimes people will give Tylenol or something like that, and they say, "Oh, my child is better. I must be helping them with their sore teeth." It probably wasn't the sore teeth. It might be a sore throat. It might be a headache that they can't tell us about. And so you probably did the right thing for the wrong reason, and that's okay. But yeah, and so this idea of a teething fever is not actually from teething. And I think we should just stop blaming everything on teething. And mind you, if you really want to go digging, it's the idea that teething causes issues may go back a couple of 100 years at least, if not more. All right. I'm seeing a few other things. Okay, quick overview of hand, foot, and mouth disease. When is it okay to come back? The answer is you never needed to exclude them in the first place. Yes, hand, foot, and mouth disease you only exclude if there's fever or uncontrollable drooling, which does not happen in most cases. And that is actually reflected on the DHS communicable diseases chart that we reviewed in last month's webinar. So yeah, they do not need to be excluded. I find when I take a temperature, I do it with a few different thermometers because you get different numbers, etc. Yeah, so first of all, temperature can vary very quickly. Um, you can see differences. I mean, sometimes I've actually seen a child where they were roomed in our clinic. They don't have a temperature, and by the time I'm seeing them, just a few minutes later, I'm like, gosh, they actually feel really warm to the touch, and I'll actually sometimes, not many times, ask to remeasure it, and now it's gone up. Temperature varies from you know, minutes to minutes, and that's okay. Um, these the details of the number don't matter all that much. A small differences in temperature are not all that important. I think it's more important to think about the long-term trend and how is the children acting, how is the child acting and behaving and things of that nature, is really more of it, because stuff does change, and it can vary. None of this is absolute. There's no one true fever. In adults, how often should you be vaccinated for COVID? Gosh, that is a good question. Since I don't see adults, I don't have the number memorized for that. If you drop us a note at at sohi.wis.edu, we'll put that in the chat in a few minutes. We can double check that for you. How long should a child wearing diapers be excluded from childcare after an intestinal virus, both diarrhea and vomiting? If they're fever-free for 24 hours, that is okay. Then they can come back, and as long as their stools are contained within their diaper. All right. I'm going to turn it over at this point. Yes, send us your questions if we hadn't gotten to them. And I'm going to turn it over to Erin to close us out here.
All right, thank you for a great event. A few logistical reminders. In a moment, we'll include a survey link in the Zoom chat. For those interested in registry credit, click the link and enter your information. Following the event, you'll receive an email with the recording and survey link. If you attended the live session and completed the survey, your attendance will be recorded online within 2 weeks. For those watching the recording, check out the DCF Continuing Education log for credit information. Thank you so much for attending today and for everything you do for Wisconsin children and families. Dr. Nafsaria, any final thoughts from you?
No, just to say again, you folks are wonderful. Happy New Year! Thank you for attending, and we always look forward to your questions and to you listening to our podcasts and our webinars. And we'll get that link in the chat here in a moment.